Hello and welcome to part 2 of Anogenital ulcer disease syndrome. As we mentioned in part 1, there are 5 anogenital ulcer syndrome that we need to know. Since we have discussed syphilis, we will move along to herpes simplex, chancroid, and lymphogranuloma venereum or LGV. So you can see that we have decided to omit donovanosis from this module teaching as it is the most rarely seen disease of the 5 listed. Let's look back to this flowchart again. Your patient arrives with complaints of a genital ulcer. You then obtain a complete medical and sexual history and assess their risk for STI. You will then proceed to perform physical examination of said ulcers and other regions. So where do we go from here? Follow the flowchart down and it will help to guide your management approach. Now keep it in mind or remember, it's always here for reference. Now let's move on to the next topic, a topic that's both common and often misunderstood, genital herpes. Despite affecting millions, herpes remains stigmatized, making it essential for us as medical professionals to bridge this gap with education, support, and effective management strategies. Genital herpes is caused by a common virus known as herpes simplex, or HSV for short. There are actually 2 main types, HSV1, which is the usual cause of cold sores around the mouth, and HSV2, which is more often responsible for genital herpes and tends to lead to recurring symptoms in the anogenital area. After exposure, symptoms can appear anytime within about 2 to 14 days, so it has quite a flexible incubation period. To make things clearer, let's go over a few key terms. First, the term initial episode refers to a person's first outbreak with either herpes simplex virus type 1 or type 2. This initial episode can be further categorized as either a primary or non-primary infection. Whether it's primary or non-primary depends on whether the individual has had a previous exposure to the other type of HSV. After that first infection, the virus doesn't leave the body. Instead, it becomes dormant or latent in the local sensory ganglia. From this point, it can periodically reactivate, leading to either visible lesions or asymptomatic shedding, meaning the person can spread the virus even if they don't show any symptoms. Asymptomatic viral shedding is when the herpes simplex virus is present on the skin or mucous membranes without causing any visible symptoms or outbreaks. This phenomenon can occur in many individuals with genital herpes, especially during the first year after infection. It's important to note that even when there are no symptoms, the virus can still be transmitted to sexual partners, which possess a risk of unintentional spread. Shedding episodes can last from just a few hours to several days, and while they often decrease over time, they can still happen occasionally. To manage this risk, using condoms can help reduce the chances of transmission, but it won't eliminate it completely. Antiviral medications are also available to lower the frequency of shedding and outbreaks. Understanding asymptomatic shedding is crucial for effective communication and management of genital herpes in clinical practice. In a recurrent episode, the recurrence of clinical symptoms is due to reactivation of pre-existent HSV1 or HSV2 infection after a period of latency and is most common in the first year with type 2. Symptoms are generally milder and certain factors like trauma, menstruation, concurrent infection, fever or even stress can precipitate an attack. Symptoms of herpes can be local or systemic and some patients may even be asymptomatic. Local symptoms typically include painful ulcerations, dysuria, and vaginal or urethral discharge. Systemic symptoms like fever and muscle aches are more common during the primary infection than in recurrent cases. Blistering and ulcers on the external genitalia or perianal region are clear indication of herpes. In first episodes, lesions and swollen lymph nodes are usually found on both sides of the body. Meanwhile, in recurrent disease, lesions commonly are unilateral and limited to corresponding dermatomes. Let's briefly discuss the clinical complications of genital herpes. Now, the most common are secondary infections, as open sores can become infected, usually occurring in the second week of lesion progression. Urinary retention as a result of autonomic neuropathy, Neurological issues, although they are rare, like meningitis or encephalitis presenting with headaches and fever. Chronic pain, as some patients may experience ongoing pelvic pain that affects their quality of life. In summary, understanding these complications is crucial for effective management. Early diagnosis and treatment are key to minimizing risks. It's also important to note what we highlight in this presentation that diagnosis is mainly clinical, although atypical presentations may warrant a laboratory investigation. These are the diagnostic methods for herpes simplex virus: HSV nucleic acid by NAT, viral culture, T-Zenc smear, and a specific serologic test. This investigation, however, is not widely available. First episode can be quite prolonged and without treatment may lead to complications. That's why early intervention is crucial. Treatment should start as soon as clinical suspicion arises. The cornerstone of pharmacological management involves antivirals, which are vital for all patients presenting within 5 days of the onset of symptoms or while new lesions are still developing. Both aciclovir and valaciclovir have proven effective in reducing the severity and duration of these episodes. However, it's important to note that topical agents are not recommended, as they have shown to be less effective. In addition to antiviral therapy, supportive care plays a key role in treatment. This includes measures for symptomatic relief, such as sitz baths for soothing ulcer pain, appropriate analgesics for effective pain management, and antibiotics only when there's a secondary infection. By tailoring our approach to the individual patient's needs, we can enhance their overall management and well-being in dealing with recurrent genital herpes. When addressing recurrent genital herpes, we have two primary treatment options: supportive therapy with antiviral therapy, where the antiviral therapy is either episodic or suppressive. Episodic therapy is recommended for patients experiencing severe or prominent prodromal symptoms like fever and significant pain. It's crucial that patients initiate treatment within 24 hours of symptoms onset for maximum effectiveness. Oral aciclovir or valaciclovir is typically prescribed, which can reduce both the duration and severity of recurrent episodes by 1 to 2 days. On the other hand, suppressive therapy is ideal for patients with 6 or more recurrent episodes per year. This approach can decrease the frequency of outbreaks by 70 to 80%, significantly improving the patient's quality of life. However, it's important to note that suppressive therapy does not completely eliminate subclinical viral shedding. Patients can expect to achieve the full effects of suppressive therapy about 5 days after starting treatment. By tailoring our approach to the individual patient's needs, we can enhance their overall management and well-being in dealing with recurrent genital herpes. Now here's a quick summary of treatment options for herpes infections. Remember this table as your go-to guide for the best approaches. When it comes to genital herpes, managing it in pregnant women is not just important. It's critical for safeguarding both the mother and baby's health. Now let's dive into this and see why it's so important. Factors that affect transmission include the type of maternal infection, either primary or recurrent, presence of maternal antibodies, length of time the membranes are ruptured before delivery, use of fetal scalp electrodes, and the delivery method. For treatment of first episode in first or second trimester, aciclovir use is associated with a reduction in the duration and severity of symptoms and a decrease in the duration of viral shedding, providing that delivery does not ensue within the next 6 weeks. Treatment should not be delayed if patient is already in her third trimester. It can be challenging to differentiate between primary and recurrent genital HSV infections based on clinical presentation. In fact, up to 15% of women experiencing their first noticeable HSV outbreak are actually having a recurrent infection. Caesarean section should be the recommended mode of delivery for all women developing first episode of genital herpes in the third trimester, as risk of neonatal transmission at this period is about 41%. The obstetrician should be informed for any case of herpes in pregnancy. In recurrent genital herpes, the risk of neonatal herpes is low and most episodes resolve on their own within 7 to 10 days without antiviral treatment. Supportive care, such as saline bathing and paracetamol, is usually sufficient. Vaginal delivery remains the preferred option unless there is another obstetric indication for intervention. Starting daily suppressive acyclovir from 36 weeks can help reduce viral shedding and recurrences, decreasing the likelihood of requiring a caesarean section. Management of a woman with genital herpes at the onset of labor will be based on clinical assessment, as there will not be time for any confirmatory laboratory testing. A viral swab from lesions should nonetheless be taken, since the result may influence the management of the neonate. For the management of the neonate, babies born by caesarean section in mothers with primary HSV infection in the third trimester are actually at low risk of vertically transmitted HSV infection, so conservative management is recommended. You should always liaise with the neonatal team, and swabs from the neonates are actually not indicated. Now that you've gone through all that theoretical knowledge, let's move on to the case scenario. So a 25-year-old male patient, Mr. M, came to clinic with complaints of fever, body ache, and painful small vesicular lesions at his genital area. On further questioning, he admits to be sexually active with at least 3 different partners this year. He claims he had a similar episode more than 4 months ago and was treated with oral medication, and the lesions cleared within 1 week. Now, what would be his diagnosis? Now, did you get the diagnosis right? How would you treat him? Okay, now that you've treated him, what other advice or management would you add? Congratulations on expanding your knowledge of syphilis and herpes. Now let's shift our focus to another important sexually transmitted infection, chancroid. Chancroid is a bacterial sexually transmitted infection caused by Haemophilus ducreyi. It primarily presents as painful genital ulcers and is more common in regions with high rates of other sexually transmitted infections. In Malaysia, the prevalence and incidence rates are quite low at about 0.04 per 100,000 population, and the incubation period for chancroid typically ranges from 3 to 10 days. The primary mode of transmission is sexual through skin-to-skin contact with open sores. Non-sexual transmission can also occur if pus-like fluid from the ulcer spreads to other parts of the body or to another person. Ulcer formation in chancroid typically begins at the site of primary inoculation. The progression starts with erythematous papules, which then develop into pustules. Now, these pustules eventually rupture and evolve into an ulcer, which is typically painful and may have a soft, irregular edge. At the site of the regional lymph nodes, chancroid can lead to painful unilateral inguinal adenitis, which is inflammation of the lymph nodes in the groin area. This can progress to the formation of buboes, which are purulent abscesses in the inguinal lymph nodes. If left untreated, these buboes may rupture and develop into ulcers. The characteristics of chancroid ulcers include being multiple and painful, with a soft, sore appearance rather than being indurated. These ulcers typically have a necrotic base and purulent exudate and are bordered by ragged, undermined edges. They bleed easily on contact, and additionally, auto-inoculation from the primary lesions on opposing skins can lead to the formation of kissing ulcers, where the ulcers appear on areas of the skin that come into contact with each other. A probable diagnosis of chancroid can be made if all of the following criteria are met. 1. The patient presents with 1 or more painful genital ulcers. There is no evidence of Treponema pallidum or HSV infection as confirmed by serological testing. The appearance of the genital ulcers with the presence of regional lymphadenopathy are consistent with chancroid. Now, what about investigations? Since chancroid is diagnosed by ruling out other diseases, it's important to test for common ones like syphilis and HSV. For a specific test of chancroid, a gram stain can be used to identify Haemophilus ducreyi, which appears as small gram-negative bacteria often arranged in a school of fish pattern. Secondly, culture is another key diagnostic method for chancroid. Genital specimens for Haemophilus ducreyi should be collected from the base and margin of the ulcer. Polymerase chain reaction, or PCR, is another highly sensitive diagnostic tool for chancroid with a sensitivity of approximately 95%. The preferred pharmacological treatment is azithromycin 1 gram stat. Alternatively, you could also give IM ceftriaxone 250 mg stat, or oral ciprofloxacin 500 mg 12 hourly for 3 days. As for management, patients should be re-examined 3 to 7 days after the initiation of therapy to assess the response to treatment. Successful treatment is indicated by symptomatic improvement within 3 days and substantial re-epithelialization of the ulcer within 7 days of starting therapy. The time required for complete healing depends on the size of the ulcer, with larger ulcers potentially taking more than 2 weeks to heal. Healing can also be slower for uncircumcised men, especially if the ulcers are located under the foreskin. It's important to bear in mind that treatment failure can also occur in chancroid. If this happens, further investigation is needed to check for possible co-infection such as Treponema pallidum or herpes simplex virus. Now, last but not least is our last topic, which is LGV or lymphogranuloma venereum. Now, lymphogranuloma venereum or LGV is caused by specific strains of chlamydia trachomatis serovars L1 to L3. Other more common chlamydial infections are caused by serovars D to K. LGV has been increasingly reported among men who have sex with men or MSM globally, and L to B serovar are common in MSM communities. In Europe, it is noted that almost all LGV cases in 2022 were among MSM, with 37 of these individuals being HIV positive. Specific data on LGV prevalence among MSM in Malaysia are limited. A study conducted in KL identified chlamydia trachomatis in 1.6% of patients with genital ulcers, indicating the presence of LGV in the region. LGV progresses through 3 stages. Primary stage, which usually begins after an incubation period of about 3 to 30 days. The patient presented with painless genital ulcers or papules and progressed to a small herpetiform ulcer which heals within a week. Some patients may develop a urethral, vaginal, and rectal discharge. Proctitis is commonly seen in MSM patients with HIV infection, with common signs including hemopurulent discharge, severe anorectal pain, tenesmus, rectal bleeding, and constipation. Unlike other conditions, inguinofemoral lymphadenopathy is not present, and 25% of cases are asymptomatic. Proctitis can also resemble chronic inflammatory bowel diseases like Crohn's disease. In secondary stage, usually begins 2 to 6 weeks after onset of the primary lesion. The second stage consists of painful regional lymphadenopathy, usually in the inguinal and or femoral lymph nodes. It will be painful, swollen lymph nodes coalesce to form buboes, which may rupture in as many as 1/3 of patients. Those that do not rupture harden, then slowly resolve. Constitutional symptoms associated with the second stage includes fever, chills, myalgias, and malaise. It also may spread systematically to develop pneumonitis or perihepatitis. In cases of rectal involvement, perirectal abscesses, anal fistulas, and strictures are possible. Rectal involvement is more common in men who have sex with men and in women who practice anal receptive intercourse. The preferred treatment for LGV is doxycycline with azithromycin or erythromycin as alternative options. Surgical treatment for LGV may require needle aspiration or fluctuating buboes for pain relief and to prevent ulcer formation, though repeat procedures might be needed. Surgical incision is not recommended due to the risk of complications like chronic sinus formation. In some cases, late-stage complications may require surgical repair. Epidemiological treatment involves evaluating and treating any sexual partners who have had contact with the patient in the past 60 days. If the partners are symptomatic, they should be treated accordingly, and if asymptomatic, they should receive empirical treatment with doxycycline 100 mg twice daily for 7 days. Patients should be followed up until their signs and symptoms have resolved within 3 to 6 weeks. In anorectal disease, symptoms should resolve within 1 to 2 weeks of commencing antibiotic therapy. In inguinal disease, symptoms might persist for many weeks and follow-up visits should be implemented. Patients should abstain from any sexual contact until they have completed therapy. All persons who have been treated for LGV should be retested for chlamydia approximately 3 months after treatment. If retesting at 3 months is not possible, providers should retest at the patient's next visit within 12 months after initial treatment. This module was also gazetted by Dr. Satya and Dr. Rupi. Thank you.